Hi, so today's topic is deafness. So before saying what is deafness, we should know the definition of deaf. So the deaf are those in whom the sense of hearing is non-functional for ordinary purposes of life. That is the definition of deaf. So the deaf are those in whom the sense of hearing is non-functional for ordinary purposes of life. That is the definition of deaf. So today we are going to learn about deafness. Deafness is nothing but hearing loss of hearing. A person is not able to hear. So that is deafness. So, hearing loss or deafness can be classified into two, organic and non organic. Organic means organic lesions. As a part of lesion, they are getting hearing loss. Non organic means without any organic lesions, that is mainly psychogenic hearing loss, that is non organic. Again, this organic can be classified into two, that is conductive hearing loss and sensory neural hearing loss. The sensory neural hearing loss can again classify into sensory and neural part, and this neural part is again classifying into peripheral and central auditory pathways. So these are the classification of hearing loss. So here actually the main classification of hearing loss, when we are telling about hearing loss, we will we'll ask or we will write for examination to understand whether it is a conductive type, sensory neural type, or mixed of conductive and sensory neural deafness or hearing loss. So the main classification is that one, conductive, sensory neural, or mix of these two. So this is a general classification of hearing loss: organic, non-organic. Organic again conductive and sensory neural. Sensory neural again two, sensory and neural. That neural part again two, that is peripheral and central hearing loss. This is the classification of hearing loss. Next we will go directly to conductive hearing loss and its management. So conductive hearing loss, from from that term itself we will understand conductive hearing loss. The problem is in the conduction of sound waves. Any disease process which interferes with the conduction of sound to reach cochlea causes conductive hearing loss. So you all know the path of sound, right? So sound has to come from outside and it enters through the pinna inside the external auditory canal, and through the external auditory canal the sound waves pass and hit the tympanic membrane. The vibration again passes through the ear ossicles, malleus, incus and stapes, and the stapes base is attached to the oval window, and that is connected to the internal ear, and these all the organ of Corte and all are present in the cochlea, and from there the hair cells are present, right? The hair cells will get stimulated and that will send the signal to the central auditory centers. So like that we can hear the sound. So the conduction path is from the external auditory meatus till reaching the cochlea. If any obstruction or any disease in between this part, and that will hinder the conduction of sound, then it will leads to conductive hearing loss. So, any disease process which interferes with the conduction of sound to reach cochlea causes conductive hearing loss. The lesion may lie in external ear and tympanic membrane, middle ear or ossicles up to stapediovestibular joint. So, the lesion may lie in external ear and tympanic membrane or middle ear or ossicles up to the stapediovestibular joint. The characteristics of conductive hearing losses are negative Rinne test, that is bone conduction is greater than air conduction, BC is bone conduction, AC is air conduction. Weber test lateralized to poorer ear, normal absolute bone conduction. ABC is normal. So before going to the characteristics, I think we should know the test for clinical test. We have what all clinical test we are doing for hearing loss. If you understand that only, you will understand what is Rene test, what is Weber's, and what is absolute bone conduction, right? So we will first see that one. So clinical test for a test of hearing. In that, first one is finger friction test, second one is watch test, third one is speech test, and fourth one is tuning fork test. So finger friction test is nothing but it is a rough but quick method of screening and consists of rubbing or snapping the thumb and a finger close to patient's ear. That is known as finger friction test. So near the patient's ear only we will test whether the friction of the fingers or snapping the thumb and finger can be heard by the patient. Next one is watch test. You know, right, the tick 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 sound you can hear in the watch. A clicking watch is brought close to the ear at a distance and the distance at which it is heard is measured. So that is the second method. And the third method is speech test or voice test. Normally, a person hears conversational voice at 12 meters and whisper at 6 meters. But for the sake of purpose of test, we will put 6 meters and normal for both conversation and whisper. And the test is conducted in a silent room, quiet environment, and the patient stands with his test ear towards the examiner at a distance of 6 meters, and we used to tie their eyes. So his eyes are shielded to prevent lip reading, and the non-test ear is blocked by intermittent pressure in the tragus. You know, this projection near the external auditory canal is known as tragus. So if we put like this, it will close the auditory canal, right? So that is tragus. So intermittent pressure is given on the other ear. The examiner uses sponde words like black night, football, daydream, or numbers with the letters X3B, A2Z, M6D, like that, and gradually walks towards the patient and measures from where he is able to hear. So these are tuning forks. So next method is tuning fork test. In tuning fork test only this Renner's, Weber's, ABC and all will come. So before that we will know how to use a tuning fork, right? So these are different tuning forks, so the different frequency tuning forks. These tests are performed with tuning forks of different frequencies such as 128, 256, 512, 1024, 2048, 4096 Hz. So all these are different frequency tuning forks, but for routine clinical practice, tuning fork of 512, we usually use this tuning for 512 Hz is ideal. A tuning fork is activated by striking it gently against the examiner's elbow or heel of hand or rubber heel of the shoe. So it will we have to activate the tuning fork by striking it in the elbow or in the heel of the hand or in the rubber heel of the shoes. To test air conduction, that is AC, to test air condition, a vibrating tuning fork is placed vertically about 2 centimeter away from the opening of external auditory meatus. So we will activate the tuning fork and we have to keep it 2 centimeter away from the opening of external auditory meatus. And the sound waves are transmitted through the tympanic membrane, middle ear and ossicles to the inner ear. Thus, by the air conduction test, the function of both the conducting mechanism and cochleae are tested. Normally, hearing through air conduction is louder and heard twice as long as through the bone conduction route. So, air conduction route is louder and long also and heard twice as long as bone conduction route. So, this is the test for air conduction. So, air conduction we have to strike the tuning fork and has to place 2 centimeter away from the external auditory meatus, and the sound waves transmitted through the tympanic membrane, middle ear and ossicles to the inner ear, and it is louder and longer than the bone conduction. And with this air condition, we can understand the function of both conducting mechanism and cochlea can be tested. Next is bone conduction. To test bone conduction, the foot plate of vibrating tuning fork is placed firmly on the mastoid bone. So you all know where the mastoid bone is present, right? It is behind the ears. This projection is known as mastoid bone. So the vibrating tuning fork we have to keep behind the ear in this mastoid bone. And cochlea is stimulated directly by vibration conducted through the skull bone. So it will stimulate the cochlea via the vibrations conducted through the skull bones, that is bone conduction. Thus bone conduction is measure of cochlea function only. Here the conduction we can't measure, only the cochlea function can be measured through bone conduction. The clinically useful tuning fork test includes, first one is Rinne test. In this test, air condition of the ear is compared with its bone conduction. Now you know how to examine the ear, how to do the test, right? How to do air conduction and how to do bone conduction test. A vibrating tuning fork is placed on the patient's mastoid, and when he stops hearing, it is brought beside the meatus. So first the vibrating, we have to strike in the elbow, heel of the hand or in the heel of the shoes and the rubber shoes, and we have to place that tuning fork in the mastoid part. When the patient says he stops hearing, then we have to take and keep it on the meatus, because we learned air conduction is louder and longer than bone conduction. So if it stopped also, the patient normally the person can hear the air conduction. So when we keep it near the external auditory meatus, the patient can or person can hear it. If he still hears, air conduction is more than bone conduction. Alternatively, the patient is asked to compare the loudness of sound heard through air and bone conduction. So we have to, if he still heard, then it is like air condition is more than BC, that is normal. And also alternatively, we have to ask the patient about the loudness of the sound also. And Rinne test is called positive when air condition is longer or louder than bone conduction. So it is normal, it is seen in normal persons or those having sensory neural deafness. So it is positive if it is air conduction is longer than bone conduction, and it is seen in normal persons, and also in sensory neural deafness also AC is greater than BC. A negative Rinne test is seen in conductive deafness. In conductive deafness, the Rinne test will be negative. There the bone conduction is more than air conduction. So that is Rinne test. Next comes Weber test. In this test, a vibrating tuning fork is placed in the middle of forehead or the vertex, and the patient is asked in which ear the sound is heard. So in this test, a vibrating tuning fork is placed in the middle of the forehead or in the vertex, and the patient is asked in which ear the sound is heard. Normally, it is heard equally in both the ears. So if we keep it like this, normally it will go to both the ears, equally in both the ears. It is lateralized to the worse ear in conductive deafness and to better ear in sensory neural deafness. So in conductive deafness, it will go to the worse ear, affected ear, where there is hearing loss, that side it will go in conductive hearing loss. And if it is a sensory neural deafness, then it will go to the opposite ear. So here the sensory neural deafness is there, means it will go to the opposite. The vibration will go to the opposite ear. In Weber test, sound travels directly to the cochlea via bone. So in Weber's test, it's a bone conduction method, right? There is no air conduction, so it is traveling directly to the cochlea via bone. Lateralization of sound in Weber's test with a tuning fork of 512 Hz implies a conductive loss of 15 to 25 decibel in ipsilateral ear or a sensory neural loss in the contralateral ear. So, there will be a conductive loss in ipsilateral. If it is a conductive deafness, then the same side, that is ipsilateral. Ipsilateral means the same ear is affected, and if it is a sensory neural, then the opposite. Here is the problem, but opposite ear to the normal ear only, it will lateralized, and that is contralateral. Opposite ear, that vibration the patient will feel. So that is Weber's test. So Weber's test, we will keep the vibrating ear hearing for or tuning fork on the vertex or in the forehead and ask the patient where the sound, this vibration is hearing. So the patient says equally. If the patient is the person is normal, then it will go equally to both the ears, and in conductive deafness it will go to the affected ear, and in sensory neural deafness it will go to the opposite ear. Next test is absolute bone conduction test, that is ABC test. So Rene's test is over, Weber's test is over, now ABC test. So in what will happen in Rene's test? We have to first vibrate the tuning fork and keep in the matured region, and when it stops we have to keep in front of external auditory meatus and ask the patient whether he is able to hear and about the loudness also. And in Weber's test, we will vibrate it at the tuning fork and we have to keep in the forehead or in the vertex. And we have to see where it is lateralizing. The vibration is lateralizing. Next, third one is absolute bone conduction or ABC test. Bone conduction is a measure of cochlear function. In ABC test, patient's bone conduction is compared with that of the examiner. So here it is compared to that of the examiners, presuming that the examiner has a normal hearing. If the examiner has a normal hearing, then we will compare that with the examiners. External auditory meatus of both the patient and the examiner should be occluded by pressing the tragus inwards to prevent ambient noise entering the air conduction route. So we have to press the tragus and we have to close the ear, external auditory meatus, so that it will prevent the ambient noise, environment noise entering to the air conduction route. If in conductive deafness, the patient and the examiner hear the fork for the same duration of time, in sensory neural deafness, the patient hears the fork for a shorter duration. So here also bone conduction is doing absolute bone conduction only. Here the tragus is closed and it is compared with the examiner, the patient and examiner's duration is compared. So in sensory neural deafness, the patient hear the fork for a shorter duration only. Tuning for vibration for shorter duration only. That is absolute bone conduction test. Next comes Schwabat's test. Here again bone conduction of the patient is compared with that of normal hearing person, but meatus is not occluded. In absolute bone conduction test, the meatus is occluded so that no other noise from outside through the air conduction pathway won't go inside. But in Schwabat's test, it is open, so the meatus is not occluded. It has the same significance of ABC test. Schwabat's is reduced in sensory neural deafness and lengthened in conductive deafness. So these are the types of hearing test we have to do to understand the degree of hearing loss, and also we can go for audiometry test also. So for understanding the degree of hearing loss and to understand the type of hearing loss, which type it's conductive, sensory neural or mixed, by doing all this test we will understand. So now we will go back to conductive deafness. So conductive deafness, hearing loss is nothing but it is a any disease process which interferes with the conduction of sound to reach cochlea, causing conductive hearing loss. And the lesion may lie in external ear and tympanic membrane, middle ear or ossicles. And the characteristics are negative Rinne test. Positive Rinne test means AC is greater than BC, but negative Rinne test means BC is greater than, the bone conduction is more than or longer than the air conduction. Second one is Weber's lateralized to the poorer ear. So which ear is affected? That side, the Weber's test, that vibration will lateralize. And normal ABC test. So it is for a sensory neural test only. There will be change in absolute bone conduction. So it will be normal for conductive hearing loss. And low frequencies affected more. Low frequency sounds are affecting more in conductive hearing loss. And audiometry shows bone conduction better than air conduction, that is BC greater than AC in Rinne's test. Same only in audiometry also we'll get with an airborne gap. Airborne gap means that is a gap between air conduction and bone conduction. Greater the airborne gap, more is the conductive hearing loss. Loss is not more than 60 decibel. Speech discrimination is good. The discrimination of speech will be good in conductive deafness. So etiology, causes for conductive hearing losses are, the cause may be congenital or acquired. So congenital causes are also there, acquired causes are also there. First one is congenital causes, that is meatal atresia. Atresia means what? Atresia means any deformity. By birth only there will be, the canal will be, any canal or any opening is closed or becomes small, then that developmental anomaly is known as atresia. So meatal atresia is external auditory meatus. There is atresia, that means that lumen becomes small or that is absent. That is meatal atresia. Fixation of a stapes foot plate. Stapes foot plate is attached to oval window, right? But it should not be fixed. It should move. It should vibrate. Then only the sound waves can be transmitted. But if it is fixed, then sound waves cannot be conducted. So fixation of a stapes foot plate, it is congenital. Okay. Then fixation of malleus head. Malleus head is fixed to the incus, right? So any fixation in these two bones or ossicular discontinuity, there is discontinuation between the ossicle. Malleus, incus, stapes, they are attached, right? If there is any discontinuity, the sound cannot be passed. So congenital cholesteatoma. Cholesteatoma, you all know, right? That is a erosion of bone. So these are the causes for congenital causes for conductive hearing loss. So meatal atresia, fixation of stapes foot plate, fixation of malleus head, ossicular discontinuity, or congenital cholesteatoma. Acquired causes are in external ear, any obstruction in the ear canal, any wax, foreign body, pharyngeal, acute inflammatory swellings, benign or malignant tumor or atresia of the canal. Any of this cause, that is in the ear canal, anything, any obstruction in the ear canal in the form of wax or foreign body or a pharyngeal. Pharyngeal is, you all know, that is a boil in the hair follicle, right? So pharyngeal acute inflammatory swelling, a swelling in the external auditory canal can cause any lesion can cause an obstruction in the conduction of sound waves, right? So in that is a external ear. In middle ear, the acquired causes are perforation of tympanic membrane, fluid in the middle ear, mass in the middle ear, disruption of the ossicle disruption, or fixation of the ossicles, or eustachian tube blockage. These are the 6 reasons in the middle ear. So middle ear, there will be perforation of the tympanic membrane, or the fluid is filled in the middle ear, or a mass is there in the middle ear, or there is disruptions in the ossicles, in the ear bones, or the fixation of ossicles got fixed, or the eustachian tube is blocked. At that time and all, we will get conductive hearing loss. So these are etiology for conductive hearing loss. So congenital are there and acquired reasons are there. So next is management of conductive hearing loss. So most cases of conductive hearing loss can be managed by medical or surgical means, medical or medicine or by surgery. So treatment of these condition is discussed in respective sections, that is in each causes. if it is because of these cause, this treatment should be given like that. Briefly, it consists of removal of canal obstruction. So if wax is impacting or foreign bodies there, or osteoma or extrosis, or any mass, benign or malignant tumors, meatal, atresia, all in this all conditions, the canal obstruction should be removed. So if there is any fluid inside, then you have to remove the fluid, right? So removal of fluid, that is meningotomy with or without grommet insertion. Grommet is like a stent. It is a meningotomy is nothing but a opening will make in the tympanic membrane so that the collection of fluid inside the middle ear is drained out. So meningotomy can be done with or without grommet insertion. Grommet is nothing but a stent like a small tube which is kept in this tympanic membrane opening, so that all if after this also there is collection of fluid inside the middle ear, means it will drain outside through this grommet. And removal of mass from the middle ear. Middle ear mass is one of the reason, right? So middle ear mass can be removed. So tympanotomy and removal of small middle ear tumors or cholesteatoma behind the intact tympanic membrane. So for that, first we have to remove the tympanic membrane, then a mass is removed. Stapedectomy, as in autosclerotic fixation of the stapes foot plate. Stapes foot plate is fixed, means that will be removed. Tympanoplasty, that is repair of perforation, ossicular chain, or both. Tympanoplasty is the repair of the perforation, tympanic membrane perforation, or ossicular chain discontinuity and all, or both. Hearing aid, in cases where surgery is not possible, refused, or has failed, then hearing aid should be suggested. So there is a treatment. In that, the main one is tympanoplasty. Tympanoplasty is an operation to eradicate the disease of middle ear and to also reconstruction for a hearing mechanism. For a reconstruction should be done for a smooth conduction of sound. So it may be combined with the mastoidectomy if disease process so demands. So if disease process and it is affecting the mastoid, then mastoidectomy also should be done. Type of middle ear reconstruction depends on the damage present in the ear. So the procedure may be limited only to the repair of tympanic membrane, then it is known as meningeoplasty, or to the reconstruction of ossicular chain, then it is known as ossiculoplasty, or both. This meningeoplasty and ossiculoplasty is their ossicular chain also they have to reconstruct, and the tympanic membrane also they have to do, means that is known as tympanoplasty. So reconstructive surgery of the ear has been greatly facilitated by development of operating microscopes and all. So these are the types of tympanic plasty. So 1, 2, 3, 4 and 5 are there. In the first time, the defect is perforation of tympanic membrane, which is repaired with a graft. It is known as meningeoplasty. So tympanic plasty in that first type is meningeoplasty. That is nothing but only tympanic membrane is replaced with a graft. So type 2, the defect is perforation of tympanic membrane with erosion of malleus. Malleus is the first bone. So there is an erosion of malleus also. So graft is placed in the remnant of the remains of the malleus on next bone, incus. So that is type 2. In type 3, malleus and incus absent. Its tympanic membrane is there, malleus and incus also gone. The graft is placed in the stapes head. That is type number 3. And type 4 is only the foot plate of the stapes is present. Tympanic membrane is not there, malleus is not there, incus is not there, only the foot plate is present. Then it is exposed to ear, external ear, and graft is placed between the oval and round window, so that a narrow ear canal like cavity is formed between that. That is type number 4. And type number 5 is stapes foot plate is fixed but round window is functioning. So in that case, another window is created in the semicircular canal, horizontal semicircular canal, and covered with a graft. So that is type number 5. So these 5 types of tympanoplasty is present, is there. So type 1, type 2, type 3, type 4 and type 5. So this is the repair of tympanic membrane or the ossicles, or both tympanic membrane and ear ossicles. That is tympanoplasty. So that is about conductive hearing loss. Hope you all understood conductive hearing loss and its management. So what is the cause? We have to treat the cause. So next comes the sensory neural hearing loss. So here the sensory neural part, the neural part from the cochlea, inner ear, through to the central hearing center. That's a sensory neural path. So any lesion in this path is sensory neural hearing loss. Sensory neural hearing loss results from lesions of cochlea, eighth nerve or central auditory pathways. It may be present at birth, congenital or acquired. So here the sensory neural hearing loss is a result of any lesion in the cochlea or the eighth nerve, which will carry the stimulus, and also the central auditory pathways. Lesion in any of these parts will cause sensory neural hearing loss, and it can be of two types. It can be congenital or it can be acquired. So two types will be there. The characteristics of sensory neural hearing loss are a positive Rinne test. So Rinne test will be positive in sensory neural hearing loss. That means air conduction is more than bone conduction. AC is greater than BC. Weber lateralized to the better ear, that we discussed when we learned about Weber's test, right? So Weber's will be lateralized to the better ear, not the affected ear. To the better ear it will be lateralized. And bone conduction reduced on Schwabach and absolute bone conduction test. In ABC test and Schwabach test, the bone conduction is reduced. More often involving high frequencies. So it's more often, and it will involve the high frequencies. Only high frequencies the patient won't be able to hear. No gap between airborne gap won't be there. It will be there in conductive hearing loss only. Loss may exceed 60 decibel. It's still 60 decibel in conductive hearing loss. It may exceed 60 decibel. Speech discrimination is poor in sensory neural, and it is better in conductive deafness. There is difficulty in hearing in the presence of noise. If other noise is there, it will be very difficult for that patients having sensory neural hearing loss to listen. So that is the characteristics. Next comes the etiology. Etiology can be congenital and acquired. So congenital causes are, it is present at birth and is a result of anomalies of inner ear or damage to the hearing apparatus by prenatal or perinatal factors. So because of prenatal or perinatal factors, there will be anomaly in the inner ear or damage to the hearing apparatus. Acquired, it appears later in the life, and the cause may be genetic or non-genetic cause, and the genetic cause may manifest late. So it is a delayed onset. Genetic cause will be late and affect only the hearing, more be a part of larger syndrome affecting other systems of the body as well. So it may be a part of other syndrome that is affecting the other systems of the body, that will cause a delayed onset of the hearing loss. Common causes of acquired sensory neural hearing losses includes infection of labyrinth, viral, bacterial or spirochetal, maybe trauma to the labyrinth or fifth nerve, eighth nerve. Example, fracture of the temporal bone or concussion of the labyrinth or any ear surgeries, and can cause trauma to the labyrinth or the eighth nerve. So third one is noise induced hearing loss because of the loud, more exposed to loud noise. Because of that is loud noise induced hearing loss. And ototoxic drugs, some of the drugs are ototoxic, so that will harm the inner ear. That will also a reason for sensory neural hearing loss. Ototoxic drug, presbycusis, that is during old age. So because of the degeneration, there will be hearing loss, that is presbycusis. Meniere's disease and acoustic neuroma, sudden hearing loss, familial progressive sensory neural hearing loss, that is genetic, And some systemic disorders like diabetes, hypothyroidism, kidney disease, autoimmune disorders, multiple sclerosis, blood dyscariasis, all this can cause sensory neural hearing loss. So these are the some of the common causes for sensory neural hearing loss. Next comes in diagnosis. History taking, it is important to know whether the disease is congenital or acquired, stationary or progressive, associated with other syndromes or not, involvement of other members of the family and possible etiological factors. So by taking the history only, we will understand this one, whether it is a genetic origin or congenital origin, or it is a progressing, or it is the same, or it is associated with any other disease in the body, systemic or any other syndromes. All the etiological factors we have to rule out. Severity, then we have to check the severity of deafness. It may be mild, moderate, moderately severe, severe, profound, or total deafness. So that severity has to be analyzed. That is through audiometry we can find out. So type of audiogram, whether loss in high frequency, low frequency, mid frequency, or flat type, all these things we have to understand. Site of lesion, where it is in cochlea, retrocochlea, or in the central where the lesion is. And laboratory test to etiological, they depend on the etiological suspect. So X-rays or CT scan of the temporal bone for evidence of bone destruction, blood counts for leukemia, blood sugar for diabetes, serology for syphilis, thyroid functions for hypothyroidism, kidney function test, all should be done to rule out the cause etiology. And the management or a treatment for sensory neural hearing loss. Early detection of sensory neural hearing loss is important, as measures can be taken to stop its progress. So early detection, if early detection is possible, then progress can be controlled. So reverse it, or to start an early rehabilitation program, so essential for communication. So early we have to detect, a lot of benefits are there. We can stop progress or we can even reverse it. Syphilis of the inner ear is treatable with high doses of penicillin and steroids with improvement in hearing. If the reason is syphilis, we can give high doses of penicillin and steroids. Hearing loss due to hypothyroidism means with the replacement therapy, by giving thyroid hormone, it can be reversed. And serous labyrinthitis can be reversed by attention to middle ear infection. We have to take care. Early management of Meniere's disease can prevent further episodes of vertigo and hearing loss. And sensory neural hearing loss due to perilimb fistula can be corrected surgically by sealing the fistula in the oval window or round window with fat. So we can seal the fistula. So if it is because of fistula, we can correct it. Ototoxic drugs means then we have to discontinue the drug. In many cases, it may be possible to regain hearing total or partial if the drug is stopped. If the drug is stopped, it can be regained. So noise-induced hearing loss can be prevented for further deterioration if the person is removed from the noisy environment. In factory and all, if they are working in a high sound, high frequency sound and all, then there is a chance of getting hearing loss. In that cases, we have to the person should be removed from that noisy surroundings. And rehabilitation of hearing impaired with the hearing aids and other devices. So hearing aids also can be used if nothing else is working. So that is the treatment for sensory neural hearing loss. So thank you. Hope you all understood conductive hearing loss and sensory neural hearing loss, and the hearing test to find out the degree of hearing loss also. Hope you all understood. Thank you.